We invented antibiotics to fight bacteria, and bacteria have fought back. Because of the misuse of antibiotics by the clinicians, by the patients, and by the industry, we have reached a situation today where most antibiotics do not work against common infections. Is this the end of the antibiotic era? Will our children hear about antibiotics like we hear about the gramophone player or the VCR player? I am Professor P K Jain, a pulmonologist and intensivist from Mumbai, and I will be speaking about the antibiotic resistance issues, the implications for clinicians, and how to prescribe antibiotics after seeing the antibiogram with an intelligent approach to antibiotic selection. When we talk about antibiotic resistance, we automatically think about acquired antibiotic resistance, which means that the bacteria was initially sensitive to the antibiotic and has now become resistant to that antibiotics. As you can see here, it was initially sensitive and now it has become resistant. But another form of antibiotic resistance, which we are not as often aware of, is an intrinsic antibiotic resistance, which means that the bacteria was never ever sensitive to that antibiotic. So in any part of the world, at any time, whether it is now or a decade earlier or a century earlier, that antibiotic never worked against the bacteria. This is an intrinsic antibiotic resistance. Pseudomonas aeruginosa, for example, is intrinsically resistant to ampicillin, amoxicillin, their combination with beta-lactamase inhibitors, first, second, and many third-generation cephalosporins, vancomycin, ertapenem, which is a carbapenem, kanamycin, tigecycline, chloramphenicol, macrolides, etc. And the funny thing is, though they're intrinsically resistant and we know they will never work, it is not uncommon to get antibiograms reporting sensitivity to these antibiotics. That is why we must be aware. So, Pseudomonas behaves like this. Enterococcus faecalis and faecium are intrinsically resistant to many antibiotics, including cephalosporins, aminoglycosides, aztreonam, polymyxin B, colistin, etc. Citrobacter is intrinsically resistant to piperacillin. Proteus is intrinsically resistant to tetracycline, tigecycline, and polymyxin B colistin. So it is very important for clinicians to check antibiotic intrinsic resistance before prescribing an antibiotic based on the antibiogram. How do antibiotics act on the bacteria? And how do bacteria develop a mechanism to avoid inactivation or killing by the antibiotics? First, in order to act on the bacteria, the antibiotic must be able to enter the bacterial cell. In the case of gram-negative bacteria, there are porin channels, and antibiotics simply enter through the porin channels. The bacteria have become smart, and they can prevent the entry of antibiotics into the bacterial cell, and they do this by one, modifying the porin channels so that antibiotics cannot enter. They can also decrease the number of porin channels so that less antibiotic enters the cell and does not reach the minimum concentration required. Bacteria become resistant to beta-lactams and aminoglycoside using this defense mechanism. In order to act on the bacteria, the antibiotic must accumulate inside the bacteria to a minimum concentration. Bacteria can avoid killing by preventing the accumulation of a minimum concentration of the antibiotic. And one way in which it does that is by developing efflux pumps in the cell wall. Efflux pumps are pumps that pump antibiotics from inside the cell outside. So when the antibiotic enters, it is immediately pushed out of the cell, not allowing it to concentrate inside the bacteria. Bacteria develop resistance to macrolides, quinolones, and tetracyclines using this mechanism. The third way antibiotics kill or inhibit the growth of bacteria is by the antibiotic entering the cell and fixing on to a target inside the cell, which is target usually is an amino acid sequence. So when it enters the cell, it latches onto the target, and when it latches onto the target, it either kills the bacteria, in which case it is a bactericidal antibiotic, or it inhibits its growth, in which case we call it a bacteriostatic antibiotic. Now, the bacteria have become smart and can prevent the antibiotic latching on to the target site by modifying the target site. So when the bacteria enters inside, it cannot latch on to the target sites, the amino acid sequence, and therefore cannot damage the bacteria. Bacteria develop resistance to various beta-lactams, macrolides, quinolones, aminoglycosides, vancomycin, dimethoquam, sulfamethoxazole by this mechanism. Another popular way of avoiding antibiotic killing is by production of inactivating enzymes by the bacteria. The bacteria produces these inactivating enzymes so that when the antibiotic enters, it is rendered inactive. Beta-lactamases, carbapenemases, macrolides, and aminoglycosides. So this is the mechanism that bacteria would use to prevent beta-lactams or carbapenems from killing them. And finally, the bacteria can upregulate the target sites so that now if the antibiotic enters, there are plenty of unsaturated target sites to prevent killing or inhibition of growth of the bacteria. When we talk about antibiotic sensitivity testing, it can be qualitative, and this is a very common way of testing in developing countries and middle income group countries, where the bacteria may be either sensitive to the antibiotic, resistant to the antibiotic, or somewhere in between, which is intermediate. A more quantitative method of testing is by the E-test or using BACTAC. The E-test is like a disc test where the zone of inhibition can be seen around the strip, and the level at which the inhibition starts can be read off. In this case, it's 1.4 microgram per ml, and that becomes the MIC. What are the major risk factors for spread of antibiotic resistance, and how can we overcome it? First and foremost, the industry. You will be surprised that 80% of the antibiotic used is not consumed by human beings, but by the industry, especially the animal husbandry, agriculture, aquacultures, etc. In order to grow better poultry, better animals like pigs, etc., antibiotics are put into their feeds. They develop antibiotic resistance, they pass feces which contaminates the plants and then consumed by man, and that's how the resistant bacteria can enter man. Disposal of expired antibiotics itself is again another big issue, and whether it is dumped in the ground or whatever is done, it can again be a source of resistant antibiotics, antibiotic resistance developing in humans. What can be done for it? Well, it has to be government restrictions or regulations on the use of antibiotics in agriculture and aquaculture industry. The community, the end users, can refuse to buy products which are labeled as antibiotic used in the industry. Transmission of resistant organisms in healthcare facilities is a matter of concerns. Patients can infect doctors and nurses, and doctors and nurses can infect the patient. Patient can infect the equipment, equipment can infect the patient, patient can infect the attendants, and so on and so forth. Antibiotic misprescription is again a big issue. wrong antibiotic selection by the doctors, wrong doses, wrong or non-optimal administration, not taking into consideration the liver and renal function, giving a broad spectrum antibiotic when a narrow spectrum antibiotic would have done, are all reasons where doctors contribute to the spread of antibiotic resistance. Also, antibiotics being given when they're not needed, like for common cold and viral or protozoal infections, or antibiotics being given for a self-limiting illness like gastroenteritis, they also contribute to the growth of and spread of antibiotic resistance. How can we overcome this? By educating. Wrong antibiotics are selected because the doctor didn't know better. Wrong dose was given, again because he did not know the dose. It was given when it was not needed, again because of lack of knowledge. So educating doctors, nurses, and healthcare workers is a very, very important part of the spread of antibiotic resistance. And finally, the patients are also to blame. Non-compliant patients who stop antibiotics prematurely because on the third or fourth day they started feeling better and they did not want to spend more money or they did not want to take the antibiotics. And equally important, inappropriate demand by patients who insist and pressurize their doctors to give antibiotics because they need to get well and go back to job fast. Self-medications by patients is not uncommon and contributes to the spread of antibiotic resistance. Here again, educating patients and community through media, mobile phones, WhatsApp, advertisements, and infomercials on television will all contribute to educating patients and community. Now, we all rely on the antibiogram to prescribe antibiotics, but there are some facts that you should know about the antibiogram. We see a lot of S for sensitive, R for resistant, I for intermediate. What do they mean? Are they random occurrences, whims and fancies of the bacteria to just develop any resistance? No, they're not random occurrences. In fact, they follow a very definite pattern of mechanism of resistance that the organism has developed. So if the organism has developed an efflux pump mechanism, you will find a particular pattern. If a beta lactamase is being produced as an inactivating enzyme, you will get a particular pattern. So we use this pattern of resistance to identify the mechanism of resistance. It is important to identify this mechanism basically because if there are many patients in a unit having that infection, whether they are independent occurrences or nosocomial spreads, can be identified because the mechanism will be the same if they're nosocomial spread. We use this knowledge of intrinsic resistance and mechanism of resistance to predict the best antibiotic in that patient, and I will show you with examples, actual examples from our own patients, how we have done that. The first case is an 18-year-old female who presented with recurrent hemoptysis for 6 months. She had purulent expectoration, greenish in color. CT scan showed bilateral bronchiectasis. The sputum showed gram-negative bacilli, gram-positive cocci chains and cluster, no fungus, and an antibiotic sensitivity report was available. It showed Pseudomonas aeruginosa. There were lots of S's to choose from, and then the treating physician wanted to start on piperacillin tazobactam along with levoflox because both were sensitive. One was a beta-lactam anti-pseudomonal, one was a non-beta-lactam anti-pseudomonal. Another physician who was also consulting on the case said he would have preferred to use a carbapenem like ertapenem because the patient was in the ward and mobile, along with cefoperazone, which is a good anti-pseudomonal antibiotic. Now, what is your comment and what is your suggestion? In order to choose the best antibiotics in any situation, you need to follow the 3-step approach. Apply the rule of antibiotic resistance. Secondly, determine the mechanism of resistance. And third, very important, apply the expert rules for antibiotics. In this case, Pseudomonas aeruginosa, rule 1, intrinsic resistance. Pseudomonas is intrinsically resistant to many antibiotics, including TG cycline, including kanamycin, which is an aminoglycoside, including ertapenem, which is a carbapenem. So you need to know that these antibiotics would never work and you need to eliminate them. So though kanamycin is seen as sensitive, ertapenem is shown as sensitive, they are not to be considered as sensitive. The second rule is mechanism of resistance. Sometimes it borders on an academic exercise, but it's interesting to know what is happening. The mechanism of resistance for Pseudomonas is like this. If it is resistant to ceftazidime and most cephalosporins, which it is here, resistant to ceftazidime and most cephalosporins, then it is an ESBL. So when we say that this is an ESBL, this is how we clinically pick it up. Resistant to cefoxidime but not ceftazidime means it is an inducible AMP-C producer. And if it is resistant to both, like in this case, resistant to cefoxetine, resistant to ceftazidime, that means it's a de-repressed AMP-C. Resistance to meropenem more than imipenem means there's an increased efflux, and vice versa, resistance to imipenem more than meropenem means there's loss of the porine channels. The antibiotic rules, again, very, very important antibiotic rules. The quinolone rule, resistance to levoflox or moxiflox means resistant to all fluoroquinolones. Here it is resistant to moxiflox, though sensitive to few of the other quinolones, all have to be regarded as resistant. Aminoglycoside rule. Well, what it says is resistance to any one aminoglycoside does not translate to resistance to the others, and we can take the report as such. The beta-lactam rule is very important. Resistance to ticarcillin or piperacillin means resistance to both. Very important because sometimes you get resistance to one and not the other. And also, this resistance spreads to the beta-lactamase inhibitor combination, which is shown as sensitive here. Now, piperacillin resistant, piperacillin tazobactam sensitive means it is reacting to tazobactam, which is not an anti-pseudomonal antibiotic at all. So, these also have to be regarded as resistant and not sensitive. Resistance to one carbapenem does not affect other carbapenems, which is fine. Resistance to all beta-lactam, including like here, resistance to all the beta-lactams, including carbapenem, which it is not, but sensitive to astringent means it is the beta-lactamase. In this case, this is not true. And if it is a metallo-beta-lactamase, the importance is you have to reduce S to intermediate and intermediate to resistant. But the other one, that if it is resistant to any third or fourth generation cephalosporin or astringent, in this case, it is resistant to third and fourth generation cephalosporins. That means you have to downregulate S to intermediate. So this meropenem and imipenem becomes intermediate. Now, so having applied the three rules, we finally select the antibiotics because we've eliminated many of them. And so you have to use two antibiotics in Pseudomonas, one a beta-lactam anti-pseudomonal, the other a non-beta-lactam anti-pseudomonal. The non-beta-lactam anti-pseudomonal is easy to choose. You will choose an aminoglycoside. Amikacin would be perfect. Now, as regards the beta-lactam anti-pseudomonal, your choice is between a carbapenem, which are S, but have been downgraded to intermediate, and astringent, which is sensitive. So a good combination could be astringent with amikacin or meropenem in high doses along with amikacin. A second case is of a 60-year-old lady, diabetic, admitted with pain in abdomen. CT scan showed a left-sided pyelonephritis with hydronephrosis, hydroureter. A DJ stenting was done and the urine was sent for culture sensitivity. We showed Enterococcus. It is sensitive to many antibiotics and therefore the clinician could have thought of starting maybe gentamicin or amikacin, could have thought about giving piperacillin, could have thought about giving any of these antibiotics. So let's see what would be an appropriate antibiotic. Let's apply the rule of 3 steps. 1, rule of intrinsic resistance, 2 mechanism of resistance, and finally the expert rule for Enterococcus. Enterococcus is intrinsically resistant to cephalosporins. Here it is resistant. It is resistant to aminoglycosides. Though it is a low-level resistance, it is not the first choice of antibiotics. It is resistant to cotrimoxazole and to clindamycin. We eliminate these antibiotics. It is not possible to pick up the mechanism of resistance based on this data. So let's apply the antibiotic rules. And the most important rule for Enterococcus is sensitivity to ampicillin. If it is resistant to ampicillin, it is resistant to all the carbapenems. That's very important. Though it is shown as sensitive to meropenem, imipenem, doripenem, it is resistant. It's also showing sensitive to piperacillin, ticarcillin, but resistant to ampicillin means it is resistant to these two. And therefore, you need to eliminate this antibiotic. Second is resistance to levoflox or moxiflox is resistant to all fluoroquinolones. In this case, it is resistant anyways. Aminoglycoside is not relevant because there is a low-level resistance anyways, intrinsic resistance. The beta-lactam rules, resistance to ticarcillin is equal to resistance to piperacillin. We've seen that. And this resistance extends to the beta-lactamase inhibitor combination. So because now piperacillin and ticarcillin are resistant, since ampicillin was resistant, we have to consider these also as resistant. Now, having applied the antibiotic rules and we've eliminated many of those which were so-called sensitive, we are left with this Enterococcus being treated with vancomycin, teicoplanin, linezolid, daptomycin, etc. or even tigecycline. And that's how you don't make the mistake of choosing an antibiotic which is shown as sensitive but is in fact resistant. And this will not only help the patient, but it will prevent the further spread of antibiotic resistance coming from inappropriate use of an antibiotic that the organism is resistant to in the first place. Thank you for being a wonderful audience. Thank you for inviting me. Have a good day.